Thank you very much, Diane. And thanks everyone for logging in this evening and participating with us. Kind of finally a beautiful day outside. So we're going to go through various different topics here. We'll go in a speed that's pretty comfortable for everyone. I gave a fairly similar presentation last year, and this is kind of fine-tuned version of that. I don't have any disclosures. I don't get paid from any drug companies or anything like that. But we will mention some brand name products as they're likely to just be more familiar, I think, in sort of the day-to-day chats. But I don't get any endorsements from any of these companies. So, as a general overview for the presentation, we will be reviewing recommendations and guidelines for prostate cancer screening. We're going to be able to understand prostate enlargement and its potential impacts on men's health. And we will discuss erectile dysfunction condition, highlighting the treatment options. So a lot of men ask, and some of them may even ask their primary care physicians, I feel fine. What is really the point, or why should I even get screened? And the goal for screening in general, not even just specific to urology, is to be able to detect a health problem or a disease state before a patient may have any signs or symptoms. And in general, men are pretty bad about seeing doctors. They really kind of tough up and say they feel fine, or they are not always willing to open up about potential symptoms. But what I would say to that is early detection is key, and we can really find something that may be preventable and if not curable if we find it early enough. And we want to be able to sort of reverse or slow the negative effects of any condition. So that's really the point of screening. And then the old adage, an ounce of prevention being worth a pound of cure, I think holds true here. So just a couple of facts and figures about prostate cancer. Since I started giving this presentation, I've had to kind of change the ratio of how many men will be diagnosed with prostate cancer in their lifetime. And when I started giving this a few years ago, it was about 1 in 9 men. And really into 2025, we're approaching about 1 in 8 men being diagnosed with prostate cancer. And this is the most common non-skin cancer in men, and actually the second most common cause of cancer-related death in men, with lung cancer being the first. Now, each time I throw up these numbers every year, the estimated number of new diagnoses usually goes up by maybe 10 to 15,000. But interestingly, the number of men that die from prostate cancer doesn't really change dramatically. So it could be that we are screening more and finding more prostate cancers, but it's not that they are becoming more serious or more lethal for men. So we can see there, though, about 35,000, close to 36,000 men are going to die from prostate cancer within 2025. Majority of these are diagnosed between ages 65 and 74. The average winds up being about 67 for most men. And it's very common for a man not to have any particular symptoms. So this is why screening exists. The American Cancer Society and really most bodies of recommendations for screening within the United States recommend informed decision making. This means that a doctor should be having a conversation with the patient and sort of a back and forth discussion about whether we should even be doing screening. And these discussions really can happen at about 50 years old for men who have more than a 10-year life expectancy. We don't want to necessarily be doing PSAs on the 80-year-old man who has a lot of other health conditions who we don't think is going to live another 10, 15, 20 years. But the 50-year-old, the 60-year-old, the 70-year-old who's in excellent health, those are the individuals that would benefit from screening. And then we get into the factors that may increase the risk for prostate cancer. African Americans are at increased risk, and any individual who has a first degree relative, so really any brothers or the father, in rare cases, a son with prostate cancer, especially at an early age, which we consider younger than 65, you want to do some earlier screening. And then there's even further high risk if there's more than one first degree relative that would be starting screening or considering that discussion at age 40. So I like to utilize the American Urologic Association more so, and they actually updated their guidance with regard to prostate cancer screening in late 2023. And really the crux of this, again, is shared decision making. You want to have a discussion with your patient, with your doctor, if you are the patient, in terms of making sure that you have that life expectancy, making sure and analyzing the risk factors and preferences for screening. So for average risk folks, compared to the general population, about age 45 to 50 for the initial blood testing. and age 40 to 45 for those at increased risk, which we mentioned some of those already, African Americans, those with a family history, or there are some people that have some genetic mutations that increase the risk of colon cancers, or females in the family that might have ovarian cancers, or certain types of breast cancers that might have mutations that are relevant for prostate cancer risk. And what's interesting is kind of the old school thinking of you get a blood test and you get a rectal exam with the doctor's finger to feel the prostate. The value of the rectal exam has actually gone down, and some studies in the new guidance that came out have supported that it's fairly subjective. It doesn't always change what we do or recommend for patients. And if you're otherwise at average risk with sort of a fairly normal blood test trend, the value of the rectal exam has actually gone down. So a little bit of anatomy here. The figure on the left here, the prostate is sort of a walnut-sized gland sitting between the bladder and the urethra. It can get larger over time. Now there's a muscular balloon above, which is the bladder, holds the urine. And then this is a cross-section, but the urine will traverse through the prostate like a tunnel. The prostate actually surrounds the urethra like a tunnel. And sometimes as it gets larger, that's what can cause our urinary symptoms if the walls of the tunnel are encroaching, so to speak. So the prostate in general, a man does not need a prostate, but it does contribute fluid and nutrients to the semen. And it actually has the connections for the ejaculatory ducts for sperm to travel into the urinary system to get to the outside to their destination. So the screening tools that we do have available, I've already mentioned the PSA. This is a prostate-specific antigen blood test, basically a protein that is floating around the blood that's kind of spit out by the prostate cancer cells. And according to the lab, a value of 4 or higher is going to be considered high or elevated. 4 or below would be considered normal. But I care more about trends over time rather than single values, because it is rather sensitive to various different issues with the prostate. If you have a urinary tract infection, if you have too much urine that's hung up in your bladder, if there is even a viral illness in another area of the body, sexual activity, all of these things can actually elevate the PSA, sort of in a temporary or false fashion rather than it being related to prostate cancer. So it's definitely an imperfect screening tool. And then for years, we were doing digital rectal exams pretty commonly once a year. This is something done by your primary care physician or your urologist. And we're checking for size, symmetry, if there's any firmness, if there's any nodules. So if there's asymmetry, if there's what I would consider a lump or bump on the prostate, it might raise some suspicion. But again, we can add in some additional screening tools now where the value of these has improved quite a bit. Their approval with insurance has improved quite a bit. And it's really just become superior to the exam with the doc's finger in a lot of cases. Now, MRI is not used as a screening off the bat. You can't just go to your doctor and say, hey, I want an MRI of the prostate. But it's used to help guide the need for a prostate biopsy if we have an abnormal blood test, or if we do happen to do an exam and find something abnormal. The radiologist will look at the prostate really in 3 dimensions, and if there's anything suspicious in there, it's given a score. And then we can actually use that information, depending on where the score falls, to recommend a biopsy quite strongly. Some of them may actually help to guide away from the need of a biopsy and reduce the need for unnecessary biopsies. We can do a targeted sample of a suspicious area if we do proceed with a biopsy. And within the next couple slides, we'll talk about sort of how a biopsy is done. Now, limitations with MRI, it is sort of a test where you have to try to remain still for 30 to 40 minutes at this point. I do see them improving over the years in terms of how fast they can get them done, the size of the machines, but people with claustrophobia may have issues, or if there's any sort of free-floating metal in the body, like a pacemaker or a gastric stimulator or pain pump, these types of things would carry a risk where you cannot have an MRI. Things like orthopedic implants, where they're fixed to a bone, generally are safe for getting an MRI. And then we're getting kind of into a hot button topic, which is liquid biopsies. Can we have a man do a urine test or a blood test and diagnose cancer? And I think that's just sort of a hot topic in cancer care in general. Right now, this test can help support sort of a probability of finding cancer if we do proceed with a biopsy. So I actually use this exosome DX test in my practice. It looks for genetic material that looks abnormal that would shed in the urine. And it's actually a home-based kit that gets sent to your home. You pee into this special device and send it back to the company. And they generate a report, and it sort of puts you along a bar graph to state what the risk of potentially finding prostate cancer would be if a biopsy was going to be performed. So it's not supposed to be used in every case. I use it in a man who's a little more hesitant to have a biopsy, or if some of the features of the MRI or the PSA are a little on the fence. It can kind of push us in one direction or another. Now, I will say prostate biopsy, the technique that we've switched to at Capital Health, has really improved and I think lessened overall risks associated with biopsy in general. The real overarching view of a biopsy is it's either done under local anesthesia or sedation. We do them under sedation in our practice because of the technique we use, which is called transperineal. Now, it does require using an ultrasound probe in the rectum, and then either a needle passes through the rectum, which is called the transrectal approach. So the needle would actually go right next to the ultrasound directly into the prostate, as you see here. In the technique that we use, we actually do it under sedation to make men more comfortable. We tape up the scrotum, and then we go through the skin area, directly through the skin under the scrotum to get into the prostate. So we avoid any contact with the rectum or the stool that might increase risk for infection. And both of these methods were able to do these targeted biopsies where we have the MRI pictures that were performed showing a suspicious area. In turn, we use the real-time ultrasound images. These pictures get overlaid, and we can actually target that suspicious area directly in real time. So it's really helped to enhance the detection. General risks of prostate biopsy overall. What I tell men, kind of the spiel I give is, you're going to have some blood in your urine for several days. You might have some blood in the semen, which can last even up to a few weeks. If we do the transrectal method, because we're putting a needle through the rectum, you're going to have some blood in the stool as well. Discomfort and pain, usually most men feel a little bit of soreness, not much pain in terms of needing medications. There can be some difficulty urinating. The number of biopsy samples we take is on the average of maybe 12 to 16, and that can cause some prostate swelling and some issues urinating. Some men may develop fever after this procedure. Doesn't always mean they have an infection, but I will say the transperineal technique has reduced the risk of infection much less than 1% just from avoiding the contact with the stool. So just switching gears a little bit from the screening and sort of prostate cancer thought process, getting into general prostate enlargement. Now, back to our anatomy lesson here. We have that prostate gland, again, sits between the bladder and the urethra, and it can constrict the urethra because the urethra runs through it like a tunnel. So natural enlargement, as men age, this is called BPH, standing for benign prostatic hyperplasia. It's actually just an indication that the cells themselves of the prostate are getting larger over time, in turn causing the entire prostate to get bigger. And then we have nerves and blood vessels that travel next to the prostate. These do aid in erection function, where if we are thinking about any form of prostate cancer treatment, if that is needed, it would impact the nerve function or the little blood vessels that travel next to the prostate and cause some difficulty with achieving erection. So prostate enlargement may or may not lead to urinary symptoms, and some of the common ones that may pop up are weakness of the stream, what I call push to start, or you're kind of standing over the toilet waiting several seconds to start up your stream. It could cause what we call intermittency or a stop and go to the urinary stream. You might be waking up at night, and varied times. It could be the urgency of needing to urinate that wakes you up as well. And some men report some dribbling as they're finishing the urine stream and they're going to zip up their pants. There's a little bit of drips that may come out. And then something called retention of urine, which is you are holding on to too much urine and not adequately emptying your bladder. Not every man with a large prostate will get symptoms. And it really depends on how much it's sort of encroaching on the walls of the tunnel, because it does have a lot of room to grow outward, but less room to grow inward where it might cause some symptoms. So what's important about urinary symptoms, lifestyle factors, and other health conditions really can impact them, and they're not just related to prostate necessarily. Fluid habits, if you consume sugary beverages, caffeinated beverages, sodas, for example, they can cause increased frequency and increased urgency of urination. Certain blood pressure medications, so-called water pills or diuretics, are certainly going to increase your urine output and put some stress on your urinary system that's going to be perceived as increased frequency and urgency. And then the diabetes condition, as well as even some of the medications used for treatment. A lot of the newer medications, things like Farxiga and others, work by allowing the kidneys to filter sugar out of the blood. By doing so, it's filtering through the kidneys. When the kidneys see an increased amount of sugar, it can actually increase the urine frequency just from a sort of almost like a diuretic effect. The sugar will pull water through the kidneys and increase the urine output overall. And then there are folks who have swelling of their legs. When we think about it, your doctors often tell you, hey, sit in a recliner, prop your feet up on a pillow, make sure your legs are quote unquote higher than the level of your heart. But at nighttime, specifically, after you've been walking around all day, big swollen legs, all that fluid, now that you're reclined, laying down in bed or in a chair, is going to get back to the heart, filter through the kidneys, and increase your urine output at night. And then the sleep apnea condition actually has an interesting mechanism by which it would increase the urine output at nighttime. Basically, when you have those episodes of stopping breathing, the heart will perceive sort of a lower blood pressure in those moments, and it works to release a certain protein that makes the kidneys filter more urine. So a lot of men come to see me and they say, "Hey, I'm 75 years old. This is just normal. I've always had these urine symptoms. Sure, they've gotten a little bit worse, but I just feel like it's normal because I'm old." And a lot of men will just simply deal with that, not knowing that there is some option for relief. So I was saying before, size doesn't always correlate with symptom severity because it more depends on how the prostate's growing internally. In the long term, prostates can become so large that they would cause high amounts of urine backed up in the bladder, which might lead to some downstream effects on the kidneys or situations where if you can't urinate at all, you would be required to have a catheter in. So, based on urine symptoms and urine symptom assessment, we would recommend potentially certain treatments. If you don't really have urine symptoms that bother you, but a doctor has just noticed you have a large prostate, we're usually just kind of watching you over time. This is an over-the-counter medication. It's popular in a lot of prostate health supplements. There's certainly a lot of infomercials that will have this in there. There's a lot of things online that you can find. Super beta prostates. There's a lot of things that have prostate DX, it might be called. And basically, they all have some component of saw palmetto among other sort of herbs and vitamins. And what's interesting is this was the only herbal supplement that was not found to be beneficial, excuse me, not proven beneficial. It was the only herbal supplement, rather, that was studied against a placebo. And while men might have reported some improvement in their symptoms, there was actually no objective improvement, meaning when we do the validated symptom questions that you fill out in the office, or if we check how much urine's left in your bladder, we did not find that there were differences in those measures, although some men would walk in and say, hey, I feel like I'm taking this and it has improved my flow a little bit. So I tell men that I don't completely endorse it. I don't also knock it to the side. It's fairly harmless. It doesn't have much side effect. And find one really that would be cheapest on the market. These are all over the counter and it's certainly safe to try. Now, prescription medications, the first and kind of tried and true drug class are what are called alpha blockers. They relax the muscle where the bladder meets the prostate, in turn creating almost like a funnel effect. That's kind of an extreme description, but in a way, they allow the urine to flow out a lot more easily. And these are your things like Flomax, which has been around for many years, and then a couple newer generation medications, either Rapaflo or Uroxetrol, both of which are, or all of which rather, are generic now and pretty cost effective. So I find that the newer generation ones may carry a little bit less risk of side effects, but they all are pretty similar. Some men may experience dizziness. This occurs if you get up too quickly from sitting or lying down. This is known as orthostatic hypotension because your body does not allow your blood pressure to rise as easily if you get up too quickly from sitting or from lying down, and then you feel just a little bit of dizziness. Stuffy nose might happen, and then there's something called retrograde ejaculation. It is a weird side effect. It's something I tell men that they may experience with these medications. Basically, the semen would go backwards into your bladder because of that funnel effect I described. It's simply that the semen's mixing with your urine, and that would be urinated out at the next time you go to the bathroom. It is not harmful to the health. The only real issue is if you're interested in fertility. If it's a younger man on these medications or fertility is still a concern, certainly we want the semen to come out forward. But really just a strange side effect more than anything else. Tadalafil is a medicine usually that was prescribed for erection health. And when they were studying it, they found that men who were taking it every day actually had a decent urine symptom benefit. We don't actually know the true mechanism of why it works, but we believe it's pretty similar in terms of the alpha blockers. And overall, the side effects a little bit different. You can get some headache, sort of a flushing, hot sensation, redness of the face or neck, and some men get some joint or muscle pain or even some upset stomach occasionally. And then finasteride is a medicine that's also been around for quite a long time. It can take 6 to 9 months really to have its full effect because of the way that it works. It works by cutting off this testosterone breakdown product. So in turn, it cuts off the food supply for the prostate. And as the prostate sees a decrease in its food supply, it's going to start to shrivel up those cells a little bit. But that takes several months really to have its full effect. Now, it's not perfect in terms of just the testosterone byproduct. So some men do notice some testosterone whole body lowering effects, in which case it might cause some erectile dysfunction, some sexual desire changes, and some men even get a little bit of breast tenderness or breast tissue growth associated with that. So generally, that is a medicine that I would reserve for a much larger prostate, sometimes in a man who is not as interested in the sexual health preservation. And then there are a host of surgery options that we can do for prostate enlargement. Now, generally, when a man requires surgery, or if we think we're headed in that direction, we need to do what's called a diagnostic cystoscopy. I keep talking about the tunnel of the inside of the prostate. Now, I need to know as a surgeon, what does that tunnel look like? Is it that there is something in my face when I go in, meaning the middle part of the prostate is sort of blown up and growing into the bladder, creating a ball valve effect? Is it actually that sort of the walls of the tunnel are closing in and the cylinder is becoming more like an hourglass appearance or even completely closed off? So this is a typical procedure. It's one we do extremely commonly. A camera gets passed through the penis to evaluate the prostate shape and size internally. It's most commonly done under local anesthesia. We use a numbing and lubricating gel and then pass the camera on the inside. We do use a little bit of water to make sure we can see well, but it's uncomfortable, certainly. It's not sharp pain. There's no cuts or incisions, but it is something that most men get through, and it's just a few minutes to give a lot of good diagnostic information. And it's really only necessary in terms of prostate enlargement if we are thinking about surgeries. And there are many, many other reasons we do this to evaluate for blood in the urine, for surveillance of bladder cancer, and various other reasons as well. But in terms of this presentation, I'm talking about it in the sense of enlarged prostate treatment. And then these are kind of hard and fast indications for surgery. If a man is catheter dependent, then they're very interested in being able to urinate without a catheter. If you're forming bladder stones, that means that there's sort of stagnant urine in the lake of the bladder, and we want to be able to open the floodgates, so to speak, or widen the channel to be able to let the urine flow out so you're not having that stagnant urine and forming stones. And then if there's failure of medication therapy, that's another good indication to go forward with surgery. A lot of the options for surgery are done under anesthesia. Many of them do not contain any incisions on the body, and they're all done through different cameras or devices passed through the penis. There are a couple that can potentially be office-based. Not many do we offer at Capitol Health necessarily, but they're on the market, and some of them are, we call them minimally or less invasive. And the goal for any of these really is to widen the channel through the prostate and reduce the obstruction that the prostate is causing on that tunnel, and ultimately to reverse any urine symptoms and, in a perfect world, to get a man off of medication as well. So this is sort of a list of surgical options here. Going into detail of each of these is beyond the scope of this presentation, but the tried and true sort of gold standard for probably over 100 years at this point is the transurethral resection of a prostate. It is an electrical loop used to shave the prostate. Some men may think of this as a roto-rooter, or if they said, hey, my dad had that, he had the roto-rooter procedure. And I describe it as if we're sort of coring an apple from the inside out to widen the channel. But you're leaving the skin and a little bit of the meat of the apple behind. But you're opening up a nice wide channel to hopefully pee like you're 20 or 30 years old. And then there are a couple laser options, one of which I want to highlight on the next slide. And then these other water-based treatments, either a steam to sort of boil or melt the prostate tissue away, or a high-powered water jet. For extremely large prostates, this simple prostate removal is actually could be a robotic procedure that's done. Generally, we make a cut in the back wall of the bladder, and it would require us sort of coring out the obstructing prostate tissue. When these other methods, it would be just too unsafe to do if the prostate is really that large. Something called prostate artery embolization is a procedure where a radiologist would go through a blood vessel in your groin to be able to cut off some of the blood supply, either half or try to do complete cutoff of the blood supply to the prostate, in turn letting the cells shrink down. Not very popular in the United States, but something in South America that's well studied with decent success. And then there are these temporary implanted devices. They have these theoretical sort of stents or basket devices that get deployed into the prostate to push open the walls of the tunnel, and then it causes actual what we call necrosis or death of the tissue. And then we remove that several days later, and then it sort of has molded after the tissue kind of sheds away, it has molded to a wider open channel. Again, not super popular yet in the United States, but these are things that are kind of hot on the market. So I wanted to give sort of a shameless plug for my partner, Dr. Joshua Eccles. He has brought expertise in what's called the HOLEP, the holmium laser enucleation of the prostate. And I feel like head to head with a traditional transurethral resection, the electrical surgery to shave the prostate tissue, the outcomes are generally pretty similar. But when you have someone in your practice that's able to offer this amazing surgery, generally, I've been referring patients to him internally for what I feel would be just excellent outcomes and really an excellent benefit. And this allows treatment of some of the much larger prostates where traditionally we were doing sort of open surgery or the robotic surgery where we can now do through a camera, through the penis. And it's become a really, really excellent procedure that he's done in the few years that he's been here. And I would say the most men should stay in the hospital overnight. If it's a much smaller prostate and the procedure is very straightforward, you may go home the same day. But pretty much all men are going home with a catheter for at least several days. And all of these surgical options, these are the general effects that we talk about people, and some of them are specific to one procedure or another, but these are kind of the overarching general side effects of most of these procedures. You're going to require a temporary catheter through the penis to allow the urine to drain well and allow the prostate to heal. That is going to remain in, on average, I would say 5 to 7 days. Some of these procedures require a hospital admission, some of them that may be less invasive or same day. Very common to have blood in the urine. There is generally a risk of long-term retrograde ejaculation with these procedures because the ejaculatory ducts hook up to the prostate in this area, and we are doing that shaving to widen that channel. We're generally causing the path of least resistance for semen to go backwards into the bladder. And most men, if that occurs to you, that generally means you had a good outcome from the procedure, but it's not typically something that's reversible. This is something that can be important to certain men or many men. And it's something that you want to understand, is this a risk of that particular procedure that you are wanting to have done, to make sure that you understand this could be permanent, because some men do experience a lot of distress from that symptom. And it's very common to get sort of temporary overactive bladder. You get a burning sensation, you get urgency and frequency. Now that the floodgates are open, the bladder goes a little haywire and it's trying to squeeze. And we could often unmask an overactive bladder that was sort of quieted down by the large prostate. Some men that does wind up being longer term. I would say most men have resolution of symptoms within 4 to 6 weeks after surgery and are feeling great. And then some men do have longer term overactive bladder that we treat in different ways. So the take home message is here. You really just want to discuss your symptoms with your doctor and have the knowledge that, we're very friendly. We'd love to see you in the office and talk to you about your symptoms and your options. And you don't just have to accept that, hey, I might be old and these symptoms are just normal. Like, My brother deals with it. My father dealt with it. I need to deal with it. And for many men, the decision really to treat is on how much the symptoms are impacting your quality of life. And we always recommend lifestyle changes first. If you're someone who comes in and says you drink a gallon of water a day, or you drink 4 cups of coffee and then you have urine frequency throughout the day, we're going to recommend you make those changes before we're throwing medications at you, and certainly well before we're recommending surgery. So just the knowledge that there really are a lot of options to help, and a lot of men do respond well to medication therapy up front. So we'll switch gears now into erectile dysfunction. Erectile dysfunction carries many definitions. Really, it's not even limited to the ones that I listed here, but generally a less firm erection. It could be one that might be firm enough for penetration, but doesn't last through to completion of intercourse, or you can't sustain it for an extended period of time. Sometimes it can be one that's totally not sufficient for penetration or totally lost. And this can happen at any age. It's just more common in older men. And reasons for that are older men are more likely to have chronic medical conditions, and the natural declines in testosterone are occurring sort of slowly over time. Whereas women go through menopause and it's more of light switch change over several months to a couple of years, the testosterone decline actually, testosterone peaks when we're teenagers or in our early 20s, and then there's sort of slow declines in our lifetime. So, a bit of a busy slide here, but just to highlight some of the major causes or the main physical or what we call organic causes of erectile dysfunction. Most of them are blood vessel issues, vascular issues. So, if you are someone that has heart disease, if you're someone that has vascular disease in your legs, if you've had stents put in your heart, these are all things where if you have small blood vessels that are damaged or have plaques in them in your heart, you're likely to have these small blood vessels have plaques in them that feed for the penis, and that could be a cause for the damage to the small arteries, leading to issues with erection. Diabetes is another one, same thing, that causes some level of vascular disease or nerve damage that can lead to sort of irreversible erectile dysfunction. So it's always good to keep your diabetes under control. Some of them are medication related. There's a couple of blood pressure medications where the side effects simply could be causing erectile dysfunction. And then these lesser percentages here, testosterone issues, prior pelvic surgery, radiation history for other reasons to the pelvic area can all cause erection issues. So we have what's called the organic or medical causes. Most of the things I mentioned, heart disease, high blood pressure, high cholesterol, diabetes, smoking, drugs or alcohol. Sleep apnea is another one. We don't quite know the mechanism of why that occurs, but we do know that men who just have a generally poor sleep cycle related to sleep apnea may have impacts on their erection health. And then some of them can be medication induced. It's not infrequent that we get a man that comes into the office and, they say they don't have a lot of other health conditions. They might not have seen a doctor for a number of years, and their blood pressure might be high the first time they see me in the office, and they're just coming to see me for an erection issue because that's bothering them. And sometimes that can be the first sign of heart disease where a urologist is actually making a referral either back to a primary care physician or recommending that a patient get established with a cardiologist to work that up. And I've had a couple patients where we found pretty significant heart disease, them coming in to see me where erectile dysfunction was the only symptom, really. So I talked some about the medications. We mentioned finasteride already earlier in the presentation, that it can cause some erection issue. And then anti-anxiety medications, antidepressants, things like your SSRIs, these can actually cause ejaculation dysfunction or sometimes causing a prolonged time to be able to reach orgasm, in which case a man sort of perceives that because they're not reaching orgasm, they're not able to sustain the erection for such a long period of time. And that's kind of how those men may hit the door. And then we have the medical causes. The opposite side of that coin is psychogenic causes. These are the things like stress, anxiety, depression. I always tell people the mood and the mind has to match the situation. If there's a ton of stress in your life, it's going to be fairly challenging to be able to have an adequate sex life if you can't sort of get that out of your mind or put that aside. And these are all things that behavioral health may be able to assist with, whether that's medication changes that are needed or talk therapy, or there's even sex therapy that can be offered in certain cases. if the anxiety is more driven by the sexual dysfunction itself. So really, a lot of these things can be prevented by lifestyle change and generally staying healthy. What I tell men in my practice is if you're sticking with your primary doctor and getting your regular screenings and taking your cholesterol medication and blood pressure medication, you're going to try and halt and slow any damage that erectile dysfunction may have seen from those conditions. But we do have options to help. And I think just the knowledge that being open with your doctor about these symptoms and having the support from your partner to try to lessen that anxiety can really aid in being able to get you some help. So when you come in, we would generally just talk to you and better understand your symptoms. What bothers you about this? What has annoyed you about it? Are you still having spontaneous erections in the middle of the night? Are you waking up with a morning erection, or have those things changed? And then we would talk to you about lab testing. Sometimes we're sending baseline testosterone if you feel you would be healthy enough and safe enough to get replacement therapy. We would want to know what the testosterone levels are. I mentioned in some cases that we may send you for a cardiology evaluation. We might be sending you to sleep medicine to think about a sleep study, and really just making sure that you know that a urologist is not a primary care physician and that we share in referring you back to your primary care physician, or in some cases, just recommending that you establish care with one if it's been a number of years, just to make sure or rule out that you don't have diabetes or cholesterol or blood pressure issues. So what's interesting about erectile dysfunction, there is not really a distinct diagnostic test or imaging test that is offered to be able to quote unquote diagnose that on paper. It's really sort of a clinical diagnosis based on a man's description of symptoms. And in that regard, even if we had a diagnostic test, which there is a ultrasound of the penis that can be done. It's very selective. I'm sure you can find radiology facilities that would offer it, but it's really a test designed to be used by a subspecialty urologist when you have erection curvature and you're thinking about surgery to repair that. We want to know what the blood flow parameters are inside the penis. It's not really designed to be used as a diagnostic test. Now, the treatment options that are available are all on demand. And even if we were able to quote unquote diagnose it officially, it's not going to change sort of the host of treatment options that we may recommend. And what I mean by on demand is they're all taken not with intent to be used daily in the morning with your other pills or in the evening with your other pills. They're just taken as needed associated with sexual activity or used as needed with sexual activity. So there are 4 oral medications available on the market. 3 of them are generic, and 1 of them is brand only. The last one, Stendra, is brand only. Most of them should provide an erection associated with sexual stimulation by helping to promote blood flow to the penis, allowing the erection to be firmer for penetration, and ideally allowing it to sustain through to completion of intercourse. And that should be until orgasm or ejaculation. They're generally taken about 30 to 60 minutes prior to intercourse. Viagra or sildenafil, usually 30 to 60 minutes before. Cialis can be pushed a little bit more towards an hour. Sometimes men even notice longer time frames for benefit. I don't really use vardenafil much in my practice. I think that Viagra or Cialis are superior. And then the only real difference between this one that I consider latest but not greatest is it just has a faster onset. It might work within 15 to 30 minutes, but it is fairly expensive. I haven't found an insurance that covers it necessarily, and it's not intended to give a better erection. Some of these we do recommend, specifically Viagra and actually Levitra, if you have that or have used that. You need to take these on an empty stomach. I tell a man if you're going out for dinner and you're planning sex that night, you want to wait about 3 hours after the meal. You don't want it to be a very large meal or fatty meal. And in a perfect world, you really should be fasting. So the meds may work best in the early morning after you haven't eaten anything from that night before. Cialis does not have any issues with food intake. Alcohol, however, will affect the absorption of any of these, and it's probably just going to be a pill sort of down the toilet. General side effects are pretty similar across the host of these. A lot of men do experience headache and some flushing sensation, usually a good indication that the medicine may work well for you. Some men do get upset stomach, congestion sensation in the nose or sinuses. Some men get a little bit of dizziness. You can get some Heart fluttering sensation. Viagra specifically can cause some bluish color change to the vision. Not very common with the other ones and not common in general. What's important about these is if you're someone who has chest pain on a regular basis and your medicine cabinet is stocked with nitroglycerin or nitro paste, you are not someone who would be safe to use this medication if those other ones are in your system. There is a blood pressure medicine as well called isosorbide dinitrate. That is another one that you have to be extremely cautious. I'm a little more lenient with that one in terms of allowing men to use that in my practice, where I would say you just have to space it out. If you take your blood pressure medicine in the morning, you must only take the oral medications for erections in the evening. But even so, those men, I'm extremely cautious, and those are two kind of dangerous medications where you can get an unsafe drop in your blood pressure, like the commercials used to say. That is a real thing that can happen. So this is a vacuum erection device. It is a plastic cylinder placed over the penis with a silicone ring sort of ready at the base to be able to hold the blood in place. And generally, these are pressure regulated. Some of them are automatic or electronic, where you push a button and it just draws the blood. Some of them have a pump mechanism. And generally, this is unnaturally drawing blood into the veins of the penis. So men report maybe about a 50% to maybe 60 something percent strength of erection that they may be desiring. And because we're drawing blood into the veins of the penis, I was saying these are pressure regulated. They shouldn't allow you to pump too high. However, it might lead to a little bit of bruising or these little kind of dots of burst blood vessels called petechiae. Some pain and numbness may be common as well because you're putting that ring around. This is kind of fallen out of favor, but it's something that I still keep in here because there are some men that sort of swear by this and really like it. I don't commonly recommend it in my practice just because it's kind of hard to come by as well. So the slide's a little more historical, I would say. A urethral suppository, it's a little applicator, gets placed usually about half an inch into the penis, and it deposits a little tiny pellet into the penis to sort of locally ooze a medication into the erection tissue of the penis. And by doing so, it provides an erection with stimulation. And this pellet does dissolve, or sometimes it gets urinated out afterwards. But it's uncomfortable. It can cause some urethral burning sensation, pain from the application. No real issue or transfer to the partner necessarily, but it can cause just pain. And even for urinations after the pellet is put in, it can cause some discomfort. So usually the pathway that I go through with for men is we try medications, and just because you respond well or don't respond well to one doesn't mean you won't try another one and have a good response. So we usually go through the host of kind of two or three medications and different dose adjustments. And then I do offer the vacuum erection devices. It's something that can be found at sort of a surgical supply, or I honestly tell men to sort of shop online for something that's cost effective because it is reusable. And then as long as you're comfortable with it, cavernosal self-injections can be done. So this is a cross section of the penis. Sort of looks like a bug's eyes here, but the two larger parts up here are the erection barrels of erection tissue that run through the penis. And then this part at the bottom on the underside of the penis is where the urethra runs through. So the injection's given either at about the 3 o'clock or 9 o'clock position, kind of depending if you're right-handed or left-handed. It is a self-administered injection that you give yourself about 10 to 15 minutes before planned sexual activity. A lot of men are scared by this, certainly from the picture or from the description. I will say if you, any diabetics in the audience, if you use insulin or if you're using any of these newer injecting agents, they have very fine needles. A needle to draw blood, if you think about it, is like an 18 gauge when you go to get your blood work. A needle to inject for the purposes of erection here is generally about 31 gauge. So the higher numbers are quite smaller and thinner. And usually this fine type of needle doesn't even have a dot of blood, or maybe if that, a tiny dot of blood that happens when you pull it out of the skin. So, it's like a little tiny, barely a bee sting is what guys report for the most part, as long as they're injecting properly. And this allows a lot better titration. We can go up on the dosing, but we have to start low because this one does carry the real kind of old commercial risk of an erection lasting longer than 4 hours. That's called priapism. That's a very serious condition. where if you do not get that addressed and bring the erection down within a good period of time, you can have irreversible loss of erections or scar tissue of the penis that forms. So we do have to take that seriously. And then you do want to alternate where you're injecting because it can start to cause some pain or hardness, a little scarring inside the skin areas if you're injecting in the same place every time. But generally, most men will get good response from this. And then there's a surgical option, which is sort of at the end of the line. And these are various types of prosthetics that get implanted. It is able to provide on-demand erection, so essentially as firm as you want for as long as you want. And there are options where there's a malleable implant, which is always sort of rigid and just sort of bent up and bent back down when it's in use and not in use. And then there are these two-piece or three-piece implants that have cylinders that go into the erection tissue, sort of a pump device that gets put into the scrotum in front of the testicles that you squeeze to inflate these cylinders. And then this up here is a little reservoir balloon in the lower abdomen that just kind of holds the fluid while the penis is soft or flaccid. When you're ready to have an erection, you squeeze the pump. It activates the mechanism to draw the fluid into these cylinders and gives you an erection. And then there's a release valve to cycle the fluid back into the reservoir. So this is an excellent option. It is sort of end of the line where generally they should last about 10 to 15 years before needing a replacement, but just like any other foreign body, it is something that's implanted, it is something that's mechanical, it could have malfunction from pressing up against something, it can sort of inflate on its own. It can be painful initially after it's put in, and then sometimes these can get infected in certain cases, which require removal. And because we dilate the erection tissue to implant these cylinders, unfortunately, this does not allow any further natural erection response, which is why I call it sort of the end of the line treatment. So one word of caution that I wanted to put in here, or a few rather, there are these online pharmacy options, and I do have a lot of men that come in and say, hey, I used Hims, or I went online to this website, and they're offering this pill that's a combination of Viagra and Cialis together. And these things can just be a little bit dangerous. Now, you are meeting with a physician for, I would say, a rather brief consultation to be able to be prescribed these medications. But using these in combination is just not the safest thing. They may not know your complete health history. A lot of people are just getting on there to be able to get a prescription filled and not, wanting to have a full visit with a physician and tell them all of their history. So I think it's important to discuss these things with your doctor, and we're very friendly and would love to have you in the office to avoid you having some issues from not receiving the best information or just a very quick consultation and a couple clicks to get a prescription filled. Shockwave therapy is on the horizon, I would say, for erectile dysfunction treatment. It has not yet received FDA approval, but it's fairly well studied by some prominent sort of men's health subspecialty urologists in the country. And what the problem is we just don't know how many shocks, for how long, for how many different sessions need to be given. And you can find clinics where this is available. If you go online and search shockwave therapy for ED, you're going to get probably hundreds of hits. But what I would say is be very careful because right now it's purely out of pocket and honestly could be hundreds, if not thousands of dollars for a treatment that's not definitively proven. The idea is hitting the penis with shock waves might break up any scar tissue or regenerate some blood vessels, but it's just not found to be proven or into our guidelines yet. Same to be said about stem cell therapy, platelet-rich plasma injections. All of these things are kind of potentially hot, not regulated, and I would just say hotly marketed in a way that it's just unsafe. So that's the biggest thing I want you to take home is most of these are considered investigational or experimental, not the online pharmacy options certainly, but these other two in the middle. And you just want to be aware of that. So when a man comes to the office, what are we going to do for you? No, this is a private space. This is purely meant to be a judgment-free zone. We talk about this day in and day out. I mean, I'm spending my Wednesday night talking for an hour about these two topics. It is extremely common. Everything really blends together. There's no judgment. What I mean by that is there's no one particular story that I've heard or haven't heard that is going to stick out to me. So anything that you feel right now you might be uncomfortable talking about, we've really heard it all and are very willing to listen to you and take you seriously without judgment. So you would usually come in, and this slide is kind of mixing the urine symptom related visit with an erection related visit. But you would meet with our medical assistant. They bring you back from the waiting room. Depending if it's urine related, you might provide us a urine sample. We do have this special device in the office to calculate how fast you may urinate or empty your bladder. There are some different questionnaires related to erection health, related to bladder health and urination symptoms that might be asked to be filled out. And then a bladder scan is a little ultrasound that can be done to check how much urine is left in your bladder. I do this very commonly in my practice because we find that men don't realize that they're hanging on to a certain amount of urine and may benefit from medication or potentially from surgery. And then we talk about your symptoms and your concerns. And really, it's not that the doctor's in the driver's seat. We are having you in the front seat with us, guiding the path of the journey. And we're reviewing the treatment options and just developing a shared plan. So some of the common questions that may come up, is there anything I can do to shrink my prostate or actually prevent it from growing? And the answer to that is not necessarily. Now, we do have that medication, that finasteride I talked about, that can sort of shrink the prostate, but it's not designed to do that just because the prostate's big. It is approved for improving urine symptoms related to prostate enlargement. I would never tell a man we're going to give you a medicine just to shrink your prostate down. If you go to any urologist and they tell you that, you should walk out and try to ask for your copay back, because we should never be giving a medicine just to bring down the prostate size without other features that are concerning, without urine symptoms that are bothering you. Now, if you don't have a lot of urine symptoms, but you are carrying a large volume of urine in your bladder, we may recommend that medication to sort of shrink the prostate and let you empty your bladder better, because that could cause that damage to the kidneys over time. And there's really no particular diet relative to prostate health. There are some schools of thought that a pro-inflammatory diet, and then I always say that when I'm in the room with patients, and I ask myself, what the heck does that mean? And it's mostly foods that might cause inflammation, things that are more processed, things that are grilled and charred and black. Um, Cured meats, for example, cold cuts might have this, and just a lot of your processed and junk foods might cause inflammation in the body. Things that you would think of that just generally make you feel unwell overall would also cause some potential urination issues or prostate inflammation. So if you consume generally healthy diet, that's really the best for you. But some men specifically ask me about turmeric or lycopene for prostate health. Vitamin E comes up occasionally. And while these things may be beneficial, I think it's more about sort of their antioxidant and general anti-inflammatory properties rather than being directly impactful on the prostate itself. So I don't endorse any one particular diet for the prostate other than to say try to stay as anti-inflammatory as you can. And then this one I've already touched on, the just nervousness about talking to their doctor about various issues or erection problem. We are wanting you to be open because it really just allows us to treat you best. So at this point, I just want to thank everyone for your attention, and I'm certainly happy to answer any questions.
Thank you, Dr. Polotti. To everyone out there, if you'd like to ask a question, you can either submit it in the chat or you can unmute yourself and ask Dr. Polotti directly. We did have one question come in that asks, is tomato juice beneficial for an enlarged prostate?
So yeah, I kind of just touched on that. Lycopene, I think that's where the tomato juice and tomato extract and all these types of things come in. It's not that it would be directly impactful, but I just feel that the antioxidant properties of tomato juice or the lycopene in there, it's not that it's going to shrink your prostate or be a miraculous cure for any urine symptoms you have necessarily, but I just think the general health benefits are there. Same goes for pumpkin seeds. I have a good proportion of patients that come in who are more into the herbal supplements, and I never knock them. I just tell them factually that it's not as well studied, they're not well regulated products, but they do find just general benefit from that.
We had another question. I thought I heard you say that I could be at increased risk of prostate cancer If someone in my family has breast cancer, how is that?
So that would be if the individual with breast cancer has certain genetic mutation. It's pretty common for breast cancer patients now to get genetic testing or at least have their cancer tested for what's called BRCA. And specifically, BRCA comes along with an increased risk of prostate cancer. So it would really be important to know if that family member has those genetic mutations before getting alarmed about any increased risk. The other thing is if it was someone who was 40 years old when they were diagnosed with breast cancer, that's much more concerning for it being something genetic rather than them being 70 or 75 years old.
Okay, thank you. Another question. With the HOLEP procedure that Dr. Eccles performs, is retrograde ejaculation a potential side effect?
Yes, it is. The only ones that I listed, and I can go back to that surgical list actually. Just take me a second. There's only a couple that should not have retrograde ejaculation. The prostatic urethral lift is known to not have any sexual side effects because of the way it works. And there are some patients who get an aquablation because that's done under ultrasound guidance. We can sort of tailor how deeply the water jet melts away the prostate tissue in the area where the ejaculatory ducts are in an effort to preserve. But these first three, the traditional electrical surgery and the two laser options, it's really about a 75+% risk of retrograde ejaculation, and it's not generally reversible.
What are the long-term effects of frequent masturbation on erectile function?
So it depends on the frequency. It's a little bit of a hard question to answer without knowing more detail, but I would say there's what's called a latency period. There is a certain amount of time that's required for the erection cycle to just kind of calm down before you're able to get another erection again. And if there's difficulty in achieving an erection at baseline, if you're masturbating twice a day or three times a day, it might be hard to perform sexually that night, for example, just because the cycle has gone through. And just the hormone and kind of blood function that occurs as an erection cycles is going to lead to issues with that.
Is there a reason why your practice at Capital Health does not perform PAE?
So the interventional radiologist at Capital Health would do that. It's not a urologist to do that procedure. I know they do it. I don't know that I've referred anyone to our hospital to do it, mostly because I would recommend going to a place that does them with a very high volume with good success rates. And I was saying it's just not as common of a procedure in the United States. So finding more of an academic center somewhere in Philadelphia, somewhere in New York City, where there's a high volume radiologist doing them with known good outcomes would really be the best option. Because any radiologist can put a catheter into your groin and put some kind of agent to block up the blood flow, but it's a little more nuanced than that.
Okay, I don't see any additional questions. I would like to thank you for a very informative presentation this evening. And I'd like to tell people that your presentation will be on the Capital Health YouTube channel in about 2 to 3 weeks if they wish to go through the slides and hear the presentation again. And I also would ask that people take 2 minutes to fill out a quick survey on tonight's presentation and to let us know what topics they'd like in the future for our educational programs. So again, thank you, Dr. Polotti. Most beneficial and very informative.
Yeah, thank you everyone for your time. I appreciate the opportunity.
Thank you, Dr. Polotti.